Right, we're live now.
Okay, thank you. Well, welcome to the virtual meeting of the Health Scrutiny panel. I remind all participants the normal rules and procedures apply. For example, comments and questions need to be directed through the chair. As we're meeting virtually, proceedings may take slightly longer, so your participation is appreciated. As per our virtual procedures, if questions have been received beforehand, we'll call you, or members will have the opportunity to raise their questions. If you're not invited to speak, then please state if you are invited to speak, state your name and specify what you're going to. Our members of the public can view this meeting on YouTube Live. They're not able to actively participate or communicate on proceedings. As this meeting is being live streamed, I remind all participants of their conduct should remain and reflect this. Thank you. Right. Any apologies for absence?
Yes, Chair, we've got apologies from Councillor Philippa Story and Councillor Geraldine Purvis is here as a substitute today. Thank you, Chair. Thank you.
I think Councillor T, do you have something to say? Sorry, you've got your hand raised. You're muted.
Just thank you for standing in for me. I don't know if it's already been explained by Caroline, but I didn't get any papers.
Okay,
so thank you very much.
Absolutely no problem.
Thank you.
Do we have any declarations of interest? Nope. Right. Next item is the minutes of the Health Scrutiny panel on the 13th of October 2020. We've read this. Do we have any questions on it? And if not, do we propose that they're a true record?
True record, Chair.
Thank you. Great. Right. The next item is the opioid dependency, further evidence. Caroline, do we have the person we need to speak to?
I don't think Chief Inspector Tomlinson's here yet at the moment, but Marion Walker's here in attendance, and I think she'd be happy to give her presentation as a starting point.
Okay, Marion,
okay,
so
everyone.
Over to you. Thank you.
Thank you, Chair. Yes, I'm happy to go with mine. So I'm going to share a presentation that's already been shared with panel members previously, so you should have seen it. I was asked to look at some specific questions which are highlighted in blue at the top of each of the slides, just to give you a bit of an overview. So I'll share that on my screen with you now and take you through that, if that's okay, Chair.
Yes, that's fine. Thank you.
Bear with me. Sorry, I think I'm just having a minor technical issue. Try that again. Share. Okay, can you just give me a nod if you can see that presentation? Yep, great.
Yes, we can see that. Thank you.
Thank you. Okay, so my details are on there if anybody has any questions later or wants to contact me. So the first thing that I've started to look at, apologies, I'm just trying to move something off the screen so that I can see the words, was the first thing I was asked to do was look at the multi-agency work that's currently being undertaken to reduce drug-related deaths and opioid dependency in Middlesbrough from my service area's perspective. Sorry, I should have started by saying that my name is Marion Walker. I'm head of Stronger Communities for Middlesbrough Council, and I support the Community Safety Partnership as well as other things. So what I wanted to do was kind of just take you through the presentation, then take questions at the end, if that's okay, Chair.
Yes, that's fine.
So in terms of that first question then, so as well as all of the great work that our colleagues are doing in public health relating to substance misuse, we're also looking at some of the issues around substance misuse broadly, which will obviously include at some points opioid dependency as well. But my presentation's more broader than that, and I'm happy to go away and take get any further details that you might need, in specifically related to opioid dependency, if I can give that information later. But I'll talk to you about what we're doing broadly. So, as you're probably already aware, our public health colleagues are looking at commission services and joining things up in an integrated commissioning model. That'll join up our homelessness services with substance misuse services. And although that's not a part of my update, our warden service and the rest of the community safety team that do fall under my remit, they play a significant role in identifying and engaging with vulnerable people and referring them on to some of those commissioned services and support services. So Middlesbrough Community Safety Partnership, for those of you that don't know, it's a statutory body and it's there as a result of the Crime Disorder Act 1998. And it's formed with representatives from Cleveland Police, Probation Service, the local authority, the Youth Offending Service, Health and the Fire and Rescue Authority. And we produce every 2 years, we produce a community safety plan and we review that plan. So let's see if this is going to work. Yeah. So we've just recently reviewed our community safety plan and we've identified the following priorities that we're going to take forward. Now, this is quite high level and there's lots of things that sit underneath this, but what I've done on the next couple of slides is I'm talking to you about how that relates to substance misuse. So the first priority is about addressing perceptions and feeling safe. So this is about us having a better understanding and being able to improve public perceptions of safety and crime in Middlesbrough and tackling crime and antisocial behaviour head on. So I've no doubt when Daryl Tomlinson joins us, he'll talk to you about some of the things that we're doing together with from an enforcement perspective as well in relation to crime and antisocial behaviour, and that includes you know, some of our dealers and what have you, but I'll come to that in a moment. Priority 2 is about tackling the root causes. So we're looking at some of the adverse experiences. Now, we talk sometimes as an organisation about adverse childhood experiences, which was really born from the theory around the toxic trio, but we've kind of expanded that a little bit further. But actually, adverse experiences can also appear with individuals as well, and not necessarily just amongst children. So we're saying adverse experiences, and also around one of the other priorities there is around looking at that trauma-informed approach. Priority 3 is around locality working, and that includes the town centre area. So I'm no doubt that you'll be aware that we've put additional resources into our town centre team and creating a safe environment for people to kind of live, work and visit in the town centre. Locality working, we've got pilot in Newport and in North Ormsby, and that really focuses on reconfiguring the relationship between statutory organisations and the community, and encouraging and supporting the collaborative approach by building capacity within our communities so that actually they're able to, and we facilitate and help people to play a role in their community. So under each of those 3 headers, these are the areas of focus that relate to substance misuse. And they fall under each of those 3. I haven't broken them down specifically, but I'll just very quickly talk you through these from a multi-agency perspective. So one of the things we're looking at is making sure that we're helping to divert young people away from criminal exploitation and county lines. And unfortunately, sometimes that leads to some young people being exploited in relation to substance misuse, particularly in relation to potentially kind of delivering or sharing or running, if you like, for drugs. Now, it isn't a major problem in Middlesbrough, I have to stress that. However, we are not complacent, and we do know that county lines is something that does run across borders. And we are working with Cleveland Police and our partners from other local authorities as well to make sure that we've got a robust strategy to deal with any issues that do arise in Middlesbrough as well. We also want to respond to issues in a timely manner and make sure that we kind of identify perpetrators and bring them to justice, and that includes drug dealing, and I'll talk a little bit about that later on as well, so one of our other priorities. We also want to make sure that we have a kind of a coordinated trauma-informed care planning approach across partner agencies, and this sits in Health and Wellbeing Board and it sits in Children's Trust, but it also sits under the Community Safety Partnership, because we know actually we need to join up and do things much tighter and much better together, and that's the direction that we start to go in now, and we've been involved in the recommissioning model as well. We also want to strengthen families to reduce the number of children becoming looked after, because we know that sometimes that can have links to substance misuse, and that can be the the result of it. Reduce mental health and substance misuse related crime. So this is about early identification of mental health issues in particular, because we know that quite often there can be a vicious cycle, isn't there, of kind of mental health and then substance misuse, criminal activity, and other vulnerabilities that go along with that as well. So if we identify that early, we think that that will help us to reduce some of the crime in ASB related to substance misuse. We also want to make sure that we identify vulnerability at an early stage and put safeguarding measures in place. So that might be around families and that early intervention model, but it also might be about vulnerable adults as well, and making sure that we put safeguarding measures in place at an early stage. So all of our community safety teams, from police officers to the council's community safety team, as well as our fire brigade, we're all trained around safeguarding. We understand what the referral processes are and the mechanisms that are in place to do that, so we can do that as early as possible. We also want to make sure that we reduce offending behaviour by increasing access to support services. And again, it's about making sure that people understand how they can refer into those services, and also that people, our wardens, for example, and some of our other neighbourhood safety teams, as well as police officers as well, that they understand how they can engage with people and then refer them on, because sometimes it's about building trust with people, isn't it? Again, I've talked about the locality working in Newport and North Ormsby. North Ormsby in particular had high levels of, well, actually North Ormsby and Newport, in fact, had higher levels of alcohol and substance misuse admissions to James Cook, and they also had higher levels of ambulance pickups data relating to drugs and alcohol as well. And then we also have the dedicated multi-agency town centre team, which often comes across some of our most vulnerable and chaotic people with chaotic lifestyles, because quite often we'll find people are begging, and we start to engage with them, and we can build some trust and some relationships up with them, and then get them to some of the support services that are available. Okay, so that I was then asked to have a look at some of the examples of some cases that street wardens and the council's homelessness team have kind of worked with. What I've done here is I've given you a couple of bullet points of what we're doing, and then on the next slide I've given you two kind of case study examples. So all of the neighbourhood safety wardens currently carry Naloxone kits. So this is an injection, a little kit. It's a bit like an EpiPen if you're familiar with those. They all carry it. They're all trained. They're also first aider trained. And they're able to, if they deem it's appropriate, they're able to inject somebody with this Naloxone device that we've got. And what that does is it immediately reverses the effect of an overdose. We've already saved 9 people's lives just since December alone, so we can see that that's already having an impact. In fact, those figures might even be higher because it didn't include last month's data. Wardens are also accredited by the Chief Constable of Cleveland Police, so we're part of that wider policing family, and we regularly gather intelligence and share information with police regarding drug dealers, so that appropriate action can be taken. And as a result of that, we've seen some direct action taken place where we've gathered information as a council service. We've provided that information to our police colleagues, and that's resulted in drugs raids taking place. So that's, you know, we have a really good partnership approach with our police colleagues, and it's working really well. There's definitely always more to do, and we'll definitely look to improve as we're going along, but we are having some really good successes recently. The council's neighbourhood safety officers, so this is not the wardens, this is the neighbourhood safety officers who kind of build up a portfolio of evidence, and some of the things that they do is they will support applications to the courts for house closures where appropriate. So this is more focused on the enforcement side. So where appropriate, if we've got evidence of antisocial behaviour, crime or drug dealing from a property, we can work with our police colleagues and with our legal teams, and we can get a house closure, and we have done that on a number of occasions already. We also work really closely with our selective landlord licensing teams with that as well, and public protection. I wanted to put these two on here because I thought it was useful for you to kind of see some examples really. Now, one of them is from 2018, so it's an older one, but it's where we had dedicated outreach workers. Just before we kind of had Jill, who's on the call here, before that post was put in place really, but it's very similar. So it's that kind of assertive outreach where they go out and engage with people and help them and coax them and kind of take them through the process. So I'm just going to talk you through these if I may. So S was homeless, sleeping on the streets and begging in Middlesbrough town centre. He was a heroin user and he wasn't engaging with any council services at all. So despite the fact that we tried to engage them, tried to get him into various different accommodation and kind of substance misuse support services, he just was not engaging with them at all. He did have benefits in place, but he couldn't access them because he didn't have a fixed address or a bank card to be sent out to. So he didn't have because he didn't have a fixed address, they couldn't send his bank card out to him. He also couldn't gain any housing in Middlesbrough at that time because he'd burnt his bridges with local landlords. So he'd done quite a lot of things when he was in some temporary accommodation, which basically resulted in them saying, "I'm sorry, but you can't stay here anymore." I'm not going to go into the detail of that because it wouldn't be appropriate, but that was the situation we were in. So 10 weeks after he'd started to engage with the community safety team, he was housed in temporary accommodation. He continued his engagement with the team and he was offered more permanent accommodation with 2020 properties at the time. This is obviously old. I'm speaking past tense here when I say he is now. It's from 2018, but I'm going to continue with it anyway. He's now attending all of his probation appointments and he's also in receipt of housing benefit. His landlord have no complaints and they said that he's doing well. He's held down his tenancy and he pays his rent and he tops it up now that his bank card's been sorted out. The team organised an assessment with CGL as well, which he actually attended. Now that's something he was not doing before. So he said he would go to appointments, but he never actually did. But this time he did because he had the support of the team. That allowed him to be put on the methadone script. The team later supported him to attend foundations. And he stated that he hadn't used heroin since and he was now feeling much healthier. I think the team were telling us at the time as well that he actually looked like a totally different person. He wanted to start begging in the town centre, so we arranged for him to work with the Big Issue and he started selling that Big Issue. And he also attends Recovery Connections as well at this time, once a week. So he was keeping out of the town centre and he was selling his Big Issue in the Linthorpe area. He was at the time when we wrote this, he was saying he now feels ready for a disc referral. So that's kind of the next level of referral to support him with secure and permanent tenancy. And he'd also asked the team if they could help him with his mental health once he got settled, which was absolutely unthinkable at the very beginning of that journey. He'd been messaging the team throughout, and some of the things that he was saying are just quoted along the bottom there, and I'll let you read those for yourself. The next example is much more recent, and it's actually from last month. So X had been homeless for about 12 months, rough sleeping, sometimes sofa surfing, but he hadn't been engaging with services at all. And this sometimes we do have a small cohort of people that just won't engage with services. When the town centre warden started to engage with him, he was a prolific beggar in the town centre and he was sleeping in shop doorways within that main precinct area, which was a cause of concern really for the businesses as well. Although he had benefits in place, he was misusing substances, which was partly one of the reasons why he was begging. And he's also burnt his bridges with housing provided, but he said he wanted to change and he wanted to stop living like this. So after a number of calls and discussions with the homeless team, eventually the landlord agreed to give him a tenancy and we got him a private rented property, and he was supported to set up his housing benefit claim in the homeless team with the homeless team as well, which was great. We got I don't know if they call it a community award anymore now, but I'm going to call it a community award. But just please be aware that might have changed. But we got like a community, we got a grant so that we could get him some white goods and household furniture and clothing. He's still continuing to work with the team now, so he still speaks to the wardens when we see him. He's got a really good relationship and he's working with the homelessness team as well as other support services. And he also, again, this guy's also started to sell the Big Issue as well, but we've got, obviously we're in COVID at the moment, so we're working with him on that. But He's now ready to address these substance misuse issues and be supported to make links with relevant agencies for ongoing support. Now, we know that he's still got a long way to go, but he's starting to make steps in the right direction. And again, there's a little quote along the bottom there from him. So he's saying he wanted to make the changes, but he just wouldn't be able to do it if he didn't have somebody there to kind of help him along with it. So for me, I think we do have some good examples, and I think some of our wardens that are on the ground, being there kind of face to face with people at that very early stage, they're able to engage with people and share information straight away with the appropriate agencies. So that's some of the that's kind of some of the examples of what we've been doing, and then finally. For me, some of the views on interventions that are needed to better support people in recovery of opioid dependency over the next 5 years. Well, what I would say is that nobody chooses to live a challenging life. Absolutely nobody wakes up and says, you know what, I think I'll go and live like this. What we find is people find themselves in situations that usually have gradually crept up on them. Individual circumstances and life experiences can just lead to people being in a certain environment that then can lead to harmful behaviours. And I think it's really important, and this is what we say to all of our teams, is that every single drug user is somebody's brother, sister, mother, daughter, son, and they do absolutely deserve another chance and the support to change the behaviour when they're ready for it. But we have to, sometimes they need encouragement to do that, and sometimes they're just not ready for it. On the flip side of that, it's also important to make sure that that people realise that, you know, if their behaviour is causing harm to the community, then you know, that there will be consequences to actions as well. So I think it's fair to say that, you know, enforcement does have a place too. I also think that we would benefit from more assertive outreach to support people to make those small positive steps for change and changing behaviour. So I think for me, what I would say is, you know, the kind of support that we've got in place at the moment through Jill and others who kind of do a little bit of that supportive outreach, and I think we've done some work in relation to some of our providers as well for that assertive outreach. But I would definitely support more assertive outreach for people to make those steps and to kind of help them get through those steps as well. That was all from me, Chair.
Thank you. Thank you very much for that. It was very, very interesting. The list has seen the older case, the newer case, interesting as well. That you're still engaging with people. That's very good. Do we have any questions? Councillor McTee, you have a question.
Thank you, Chair. Can you hear me all right?
I can do, yes.
Yes.
And Councillor Rooney after.
Thank you. Marion, I don't know if you're the right person to ask this question. If you're not, perhaps you can pass me on to somebody who can. We hear various, excuse me, various ways of which the homeless should go about finding somewhere to live. So can you tell me the correct way? If somebody came to me and said, look, I'm homeless, what advice do I give to them? Where's the first point of call, etc., etc.? Can you just guide me through it so that I can make notes and then pass it on as and when, please?
Yeah, if I may, Chair, I think what I would say is I'll get you a full script so you know exactly what it is you need to do. But what I would say, and this is not necessarily to take away and say these are the exact things, but we have a team. I don't know if Jill's still able to speak, but she may be able to answer the step by step. But what I would say in the first instance, if you're concerned about somebody who is homeless and you don't know where else to go, if you speak to the warden service, they know the exact referral processes to go through. I'm not saying that that's where you should go every single time, because you should go direct to source. I don't have those contact numbers with me straight away, but we do have an out of hours phone number for our homeless team. We've also got an in-hours phone number for our homelessness team, and the wardens know how to make those referrals, and they also know how to make referrals to other services as well, depending on the circumstances of each individual. So unless Jill's got the details of the homelessness provision, I'll get that to you later, Chair.
Thank you. Can I ask another question, Chair, please?
Yes, okay.
Thank you. You mentioned 2020 properties. Did I hear that correctly?
Yep.
Can you explain it, please? I've never heard that expression before.
Oh, my apologies. They are they're an organisation who have a range of privately rented properties, and we go to lots of different housing providers. They're not the only one that we use for sure, but we do have the ability to go to some of these some of these kind of landlords who've got multiple properties, and we're able to kind of place people in those properties as well. So we don't necessarily we don't necessarily have like a massive commissioned piece of work that we do with them. What we'll do is, and quite often it depends on the circumstances of the individual. They might not be able to be within a geographic area for one reason or another, so we might have to look further afield. So sometimes we'll just go to private landlords. So in that instance, that's who it was that we worked with, but it could have been anybody. It's
Okay.
a private landlord.
Finally, one final question, Chair, if you indulge me, please. The naloxone injections. Do you have to have the what shall I call them?
Training.
Patient. Do you need the patient's? You're nodding, so you know what I'm going to ask. Do you need the patient's permission to give the injection? You can't force it on them. Is that correct?
No, that's not necessarily true, because quite often the patient will be unconscious on the floor near death,
Right.
and we give it, and we're trained. So we're trained to identify when it's appropriate to use it and when it's not appropriate to use it. And we
Thank you.
certainly do not want to use that. I think it's worth just pointing out that you cannot harm anybody by giving the injection. It's not going to, it's not going to cause somebody's death by giving them that injection. So when you get to the point where somebody's unconscious, you've spoken to somebody who's been next to them, or it's really evident that they've taken an overdose, the only thing that's going to save this person's life right now, because I can't, an ambulance is still going to take time, is to give them that injection. We would give them that injection, and we're fully trained in order to do that.
Thank you. Thank you, Chair.
Okay. Councillor Rooney, I think, was next.
Yeah, thanks, Chair. A couple of things, Marion. You began the presentation talking about public perception and feeling safe. And my view is language is really, really important in that, and how we refer to people. Just as an example, the phrase that a lot of people say is the homeless, and it's not. It's people who are homeless or have nowhere to live. And then you also personalise that further down in your presentation when you talked about, who might be in these positions. What are we doing to try and turn that around so we are speaking more positively in the press? And is there anything more that we can do? Because I am really concerned, particularly some people within the local authority use either the wrong term because they don't understand it, or they have an approach to something that gives a very negative position of a situation which doesn't help in the end. Thanks.
Thank you. So I think what I was trying to do throughout the presentation, which is why I put that slide in at the end, is people find themselves in situations because of circumstance. Nobody chooses to be in a situation that they're in. Absolutely, they do not. And we need to make sure that we support people to give them the opportunity to access the services that are available. And you know what, we all have the right to say no if we're not ready for something yet, but that doesn't mean to say that we should be negative absolutely about a situation, because people are victim of circumstance, just as we all are around various different things. And if you think about anything in our lives that we can think of, I'm in this position because of circumstance. So I think I always try to make sure that I quantify it by saying that it's not a negative thing. People find themselves in that situation because of circumstance, really, which is what I try to do at the end of the presentation.
Yeah, thanks, Marianne. I get that. I'm talking about how we make sure that we're all taking that approach, basically, and whether there's anything more that we can do as an authority to kind of further that approach. My second question, Chair, just very briefly, you talked about early identification of mental health issues. How are you doing that?
So we're not trained mental health professionals, absolutely not. But what we can see, and this is where those kind of adverse experiences come in. So we know that if we've got certain things that are happening either in a family or with an individual, what we do is we try to, certainly from a warden perspective and a community safety perspective, we'll try to build up a relationship with people and try to kind of get to know that individual a little bit better or that family a little bit better. It's what you find just by having conversations with people is that, and by building up trust and relationships with people, is people start to open up about all kinds of things to you. Soon as we identify that, and previously, you know, if we'd have identified that, somebody said, well, do you know, actually, I'm feeling really low, or even worse, or they've got other feelings, then we would have made a referral. But what I'm trying to do now is make sure that, and we've trained all of our warden staff around the kind of the what to look out for. We've got a number of mental health first aiders, so we can look at that in terms of our staff as well. So we're not just looking at it from a community perspective and how we identify it in the community by building up those relations and asking questions through training, but we're also looking at it from a staff perspective as well.
Thank you, Chair.
Thank you. Did Barry, Councillor Cooper, did I see your hand up? Do you want to go ahead?
Thank you, Chair. Just when we were talking about phone numbers, it came to mind that I always carry this with me. And what that is a Middlesbrough Council business card. And on the back of it, you've got all the numbers that you need. So it's quite handy to have in your phone or your wallet. One other question I'd just like to ask. I understand West Lane Hospital's reopened. And I was wondering if we've built up a relationship with them since they've reopened in relation to mental health. Thank you, Chair.
In terms of the warden service, we're not working directly with West Lane Hospital at this point. But what I would say is, as part of the broader conversations that we have, so we have daily meetings with our police officers. I think Daryl's on the line there, and he'll probably talk to you a little bit about the kind of daily briefings that we've got, and then we've got our fortnightly meetings where we're looking at the kind of the intelligence from a multi-agency perspective. We do have our health colleagues on there as well. We've got a really good relationship with Tees Esconwee Valley Mental Health Trust. So if we've got if we've got issues that we need to discuss, and that includes the community safety partnership and further down the chain, we can have discussions with them about, you know, how we link in and how we link in with, Rosebery Park, for example. We've got a protocol in place where our community safety officers have helped to they helped put a policy in place specifically around people who might be kind of getting rowdy and loud, and we linked in with the police around that as well. So we've got a really good link with the Tees Esconwee Valley Mental Health Trust.
Yeah, I think we need the holistic approach to this. I think in the past that perhaps things weren't connected together, but it does sound like to me you're actually connecting things together, because it's no good one agency knowing about a problem with a person if the other agency that's dealing with that person doesn't. So you've got to try and get it together, and it sounds like you are, because in the past, if someone's had problems and they're having problems with drugs or having some of that, they will have other problems in life, and you've really got to see it together and take the holistic approach. So I'm pleased you're doing that.
I think the other thing, Chair, if I just may add, is that sometimes, you know, the person you think is the right one to kind of engage and have that kind of assertive outreach with Marion, for want of a because just to randomly select a name, actually it might be that it's the warden who's the best person to start at building that relationship. Be that it's somebody from the early intervention team, from children's social care. It might be that actually a police officer's got a really good relationship. It might be somebody from the voluntary and community sector. It could be Middlesbrough and Stockton Mind. It could be a whole range of different people. It could be one of the substance misuse providers that they just happen to strike up a connection with. What we do is we just make sure that the right person builds up that relationship and then knows how to refer onto appropriate services at the right time. So that's what we're trying to do.
Absolutely. In this day and age, nobody should be on the streets at all. Sorry, is that? Someone said that. Sorry, I'm just saying that nobody should be on the street in this day and age. If they have a life choice to be there, it doesn't stop us keep in with them, talking, asking them, and cajoling them to come in. So I think we need to take that approach, and ideally, nobody should be on the streets. Sorry, is there someone? There was Councillor Tom Mawson, then Councillor Halawi. Councillor Mawson, do you have a question?
Well, thanks, Chair. It's a comment, quite brief. I'd like to thank Marion for an excellent presentation and coming out with a very difficult area to work, coming out with some positive actions. And as you said, people don't choose that type of life, and people chose a challenging life, but not people who are homeless. Thanks, Chair.
Thank you. Councillor Halawi?
Thank you, Chair. I have a couple of questions, Marion, that just are factual, and then a couple that might need a bit of a longer explanation. I'll just ask two if you want it first, Chair, if someone else might like to ask. On one of the comments at the end of one of the final slides you showed, Marion, I think I understood that you said the situation could improve even further if we had a more assertive outreach to support people. I thought, are there some barriers that are preventing us having this outreach approach, this assertive outreach approach, as you referred to it as?
So in terms of that one, I think really what I'm saying is if we were able to identify any external funding from anywhere, we've got to work within the envelope of cash that we have at the moment. There's absolutely no doubt about that, and we've trained all of our neighbourhood safety officers to be able to do that supportive element and some element of that kind of assertive outreach. But the reality is, if we were able to have more people dedicated, more like what Jill's doing at the moment, and kind of more assertive outreach, I think we would have even more benefits, is what I'm saying.
Yeah, I think that's what I thought it would be. Behind it all would be a funding issue. Yes, okay, thanks. Just to confirm that. In terms of the cases that we looked at, they were both successful, and that's very reassuring to read those. Is it sometimes worth considering the balance of having sight of some cases that are less successful, so that we see a sort of train and progress of support that's put in, and despite all of these different agencies working to support people, I just wondered if on the other side we get people who, for whatever reason, unfortunately, don't manage to engage, so we can't always potentially be successful.
Absolutely. So we do have a very small group of individuals who we are trying to engage with. There's a number of different, I don't want to say too much because you might be able to identify the individual, but we definitely do have a small group of individuals who are using substances. I don't know, sitting here right now, those are opioids, but they're certainly some substances, and certainly alcohol is involved, and they refuse to engage with services. And the reason that they refuse to engage with services is because the circumstances that they're in. It's not because they're there because of choice, and they suddenly woke up and said, I don't want to work. But what I would say is that there is. And I'm trying to be careful about the terminology here, but there is some element of choice in that, and the choice in that is that actually what I'd quite like to do at the moment is I don't want total abstinence, and if I go into this particular accommodation, I'm not allowed to take any drugs and drink any alcohol. Therefore, I would choose to stay as I am at the moment, even though that's a really dreadful and awful situation to be in. That's what I would prefer to do, because it allows me to carry on with the behaviour that I'm currently caught up in that cycle. So it's not necessarily a choice that kind of in a rational situation you would make. However, in that moment when it's kind of consumed every single thought that you have and every single thing that you do, this kind of way of life is consuming everything. That's the situation that we find ourselves. And we do have a situation where we do have a small group of people that's the situation.
Thank you. Shall I ask some more questions, or does someone else want to come in, and then I'll come back, Chair?
Can I just add to a point I made earlier? Another thing that we have to bear in mind is that there's the unseen homeless, the people who are surfing on people's couches, a couch surfer that might go from house to house to house. They're still just as homeless, and they could still end up on the streets. So I'm sure that you look into that as well. So that's just a point. Is there anybody else other than Alma? No, carry on.
I was wondering about when you have your multi-agency meetings to discuss the various situations. How do you in fact incorporate the voice of the service users in those multi-agency meetings for certain aspects of the deliberations?
So the Community Safety Partnership is a strategic meeting. So at those meetings, what we do is we have representatives from CGL at those meetings, and quite high level, and we have, or we certainly have representatives from our public health colleagues be at those meetings, and they'll be able to feed in anything that they've done. So we don't necessarily bring those along to the meetings to give their voice directly at those meetings, but we feed it back through. Yeah. Yeah.
So at the levels of meetings, you do incorporate the voice of the service users to have their perspective, maybe people who have recovered or people who can give that extra dimension. I just wondered if that happened.
Absolutely, across the board, part of that multi-agency work, and we'll work with Jonathan's team, for example. I can see Jonathan's on the call, and I know that well, Jonathan obviously commissions some of those services, or the team commissions some of those services, and they do lots of work with service users, and they feed that back through the chain. So. And I think it's really important, really, that people who do take part in surveys or focus groups or discussions, that they understand that that actually goes right the way up to the top in terms of our strategic thinking and the way that we start to shape our multi-agency working.
Thank you. I just feel that's reassuring to know that I was just hoping that's how it worked. I wasn't quite sure. Just a couple of factual things then.
Can I just interrupt there? I'm also conscious that Chief Inspector Daryl Tomlinson is on the line and he may have to go. I don't know whether you can.
I can keep my questions till later, David. If that's fine.
I just want to check with Chief Inspector. Are you all right to hang on at the moment, or do you need to come in here?
No, that's fine. I'm quite happy to listen to the inspector. Thanks, Chair.
Okay, thank you. If you've called in, you'll need to dial. What is it? It's #6, #5.
It's *6.
*6. Yes. If you want to type in *6, we'll be able to hear you. Thank you.
There we go. Can everyone hear me?
Yes, we can. Thank you.
Good afternoon and evening. Sorry, apologies for my delay in getting into the meeting, and I do apologise for the lack of my computer skills to get my face up on the screen. It's down to IT issues as well. I do apologise. Yeah, just Chair, I've got till about 5:15, so I've got half an hour left of my availability. If you'd like me to go through an overview of the issues that you wanted me to talk about, I'm quite happy to do that now.
Yes, please, if everybody's happy with that, I think it would help if you do that. Thank you. Go ahead.
Not a problem. So, yeah, my name's Daryl Tomlinson. I'm the Chief Inspector in charge of Middlesbrough Neighbourhood Police Team. And obviously I'm here today to talk about not just Middlesbrough's response, which is obviously I'm hopefully an expert on, but Cleveland's in general. And obviously apologies I don't have a nice presentation as Marion did. I must admit that I'm a bit of a stand-in for one of our Chief Inspectors called Scott Cowie, who is the Chief Inspector in our Community Safety Team and has been a project lead for the heroin and crack action area over the past year, where he's been responsible for leading a project with partners, exploring a lot of the problems that we've had and experienced across Cleveland and across the North East with drug dependency. So what I wanted to do is talk a little bit about what Scott's done, a little bit about what we're doing to tackle the drug-related deaths and the dependency, and then I'll cover off a couple of the points that's been asked already. So, are you happy for me to speak as a Middlesbrough perspective, directly for Middlesbrough? Is that okay?
That's fine. Yes, you do speak as you wish.
Right, no problem. So, obviously, our priorities within neighbourhood policing and with the police come around 4 areas, which comes really into this is vulnerability. And one of the things that Marion is obviously spoke about is about the vulnerability of users, the vulnerability of suppliers, and how people end up in the position that they are, some life choices, some circumstance. And obviously through the HMIC reports over the last 18 months, we were found exposed in those particular areas. So we've gone through vast training programs and vast change culture around recognising vulnerability. And this is a particular area of drug use and supply that we've actually had a massive focus on. But alongside that vulnerability priority is tackling crime and antisocial behaviour, and we've got to recognise that in some circumstances, enforcement has to be one of the options that we explore, but it has to be proportionate in line with the individual that we come into contact with. And one of the big things that we deal with as neighbourhood officers across Middlesbrough is dealing with people as individuals, not stereotyping, not putting them into categories of drug users or non-drug users, but to treat every individual as we find them. And the way that we do that at the moment is obviously through training and briefing. But Marion touched upon the daily sort of meetings that we have, and the fortnightly meetings and the monthly meetings that we have to discuss the most vulnerable and the most pressing issues within Middlesbrough at this moment in time. So just to give you a bit of context, every morning I chair a morning meeting which discusses the last 24 hours of threat, risk and harm across Middlesbrough and around the priorities that we're going to set for that particular day in line with the force priorities. A member of Marion's staff dials into that from a local authority perspective. We have housing providers, community safety, the fire brigade, youth offending team, victim care and advice service. We've got a whole host of people, usually around 10 attendees every morning, dial into a meeting where we discuss crimes, we discuss antisocial behaviour issues, and we discuss vulnerability. And a lot of the issues that we do discuss are linked to drugs, or drugs has some sort of element within what's happened, or whether it's played out, whether that be violence, whether it be supply, whether it be an antisocial behaviour incident. We do find that drugs and alcohol have a route into most incidents that end up being reported to the police. Wider in Cleveland then, when we're talking about how we're going to deal with that, we've got a load of different options of how we deal with people. So we've got a divert scheme in custody to deal with those at really low level offending areas, to divert them away, to support them and to assist them to try and rehabilitate and find the right service to deal with their needs. So if a low-level user or someone who uses drugs comes into custody, we have a healthcare professional in there, and we have what's called a custody and diversion team. So the healthcare professional will deal with any medical issues, any drug dependencies, and ensure that that person gets the right care they need. They are then referred to the diversion team, who then look at referring them on to the relevant providers like CGL and others across Middlesbrough to try and give them the support that they need. So with those lower level offenders, we try and divert them away from the issue and to try and rehabilitate them rather than put them through a court process, which inevitably will result in some sort of punishment, which doesn't really solve an issue. So there's one of the main routes that we're trying to divert people at the moment. That morning meeting drives a lot of business. We set action tasks, set problem-solving plans up place, set in safeguarding measures, and look at it as bespoke to that particular individual who's involved in the incident. Custody procedures include risk assessments, obviously include those healthcare professional visits and the liaison and diversion teams as well. We have a community safety team that Scott runs, I've just talked about, who runs alongside our team, that work around mental health. And a lot of the mental health issues and cases that have repeat callers and repeat service users come in have some sort of element of drugs dependency, whether it be opiates or whether it be painkillers and prescribed medication. For the higher end of sort of disruption, obviously we are getting a lot of calls and a lot of reports at this moment in time around street level dealing, around it being blatant, around it being in public view, and we have to show that we can't tolerate that. So our neighbourhood teams, primarily, their role and function is to disrupt those street level dealers that are causing a lot of issues on the streets in terms of traffic flow of people, antisocial behaviour, discarded drugs and needles. And we work with Marion's team to identify those locations, put in the enforcement work, support the users, the service users that are potentially attending that address. But ultimately, we want to try and close down some of those properties for the communities that have to live in the same streets or next door, because having lived next to unsavoury characters in the past, you realise that it really does have a massive impact on your life when you have some sort of drugs activity going on in surrounding premises. So we've got to recognise that vulnerability, not just to the neighbours, but also to the service users that are going to those addresses. So we take on most of the drugs investigations at that street level. And then above that, we have obviously our organised crime group management, where we identify those that are really making large profits and causing a lot of misery out of crime and putting our resources into disrupting that. And then we have our CID and crime investigation departments that deal with the drug-related deaths, which unfortunately we are high in the northeast in relation to that. But each and every investigation is obviously dealt with professionally to try and understand the reasons why that individual has ended up in that position. One of the interesting facts, obviously looking at why and what drugs are causing these issues, is that over half the deaths that were actually reported of drug poisoning were unable to actually determine which drug is responsible for the death due to the fact that the individuals have a combination or a cocktail of drugs, whether it be a combination of class A, B or C drugs, and then you go into your prescribed drugs. It is very prevalent that each and every user, unfortunately, that dies has a combination of a multiple number of drugs. So it's really difficult to try and put the statistical element to, well, what drugs are causing the death. And it's really difficult to say because of the number of drugs that are being found during the coroner's reports and the investigations. Let me just have a little bit of reading. So some of the harm reduction schemes that we've got in place include the divert scheme to divert people from the criminal prosecution system into rehabilitation. We have a youth engagement meeting around how we educate, how we support youth, how we try and divert youth from actually getting involved in drugs and antisocial behaviour and crime. We are looking at new programs to educate children in schools, but not as a single agency. We can't go into schools as a police agency and say, this is right, this is wrong. What we have to do is work with our providers. And I think there's schemes on at the moment where we'll be combining with service users providers with the local authority to deliver an holistic approach to the dangers of drugs, rather than the police going in and saying, you can't take drugs because this is going to happen to you. A couple of interesting sort of trends that we're seeing at the moment, particularly in Middlesbrough, is that a lot of the enforcement work that we are doing at the moment is yielding very little in terms of recovering heroin. It seems to be a generational change that heroin is a dying drug in terms of the younger generation picking it up. We're now seeing more misuse and abuse of prescribed drugs, drugs imported over the internet in terms of tablets, painkillers, sleeping tablets, and people tending to move towards cocaine and crack cocaine. And they're the sort of trends at the moment that we're seeing across Middlesbrough. I'm just having a quick look at my notes. So Scott Cowie's work, the Chief Inspector who was in charge of the heroin and crack action area, obviously worked with a lot of partners, worked around the heroin assistant treatment program, worked with the PCC's office to really give us an understanding of how we can support service users, how we can prevent them coming into the criminal justice system and look at rehabilitation rather than potentially putting them through short-term custody sentences for possession, which cause a lot of time, a lot of administration and a lot of bureaucracy in trying to get these people to court for what appear to be minor offences. And we need to look at our strategy around vulnerability and engagement to try and divert them and work with them rather than bring them into custody and put them in prison for a couple of weeks for them to come back out and start that same cycle and same journey. One of the big things, obviously, that Marion has expressed and talked about is the joint working through the Community Safety Partnership. COVID has brought many challenges in terms of our face-to-face meetings and our briefings and joint patrols, but we have come a long way in the last 9 to 10 months with Marion's team and street wardens working closely with our neighbourhood teams. I'm very happy to say that our neighbourhood teams are nearly there in terms of the numbers that we were promised back in January, February time, and that we are nearly at the full model of having at least one PC and one PCSO per ward across Middlesbrough. And I think some of the councillors will have been receiving some of my news letters and updates, and hopefully we're going to move from strength to strength in terms of not just numbers, but the work that we're delivering. And a lot of that is around engagement. We need to get the communities back on side. We need to build the trust and confidence. We need to improve the reporting mechanisms that we've got. We know we've still got some issues and some ways to go, but I think myself and Marion, as leaders in our both organisations, are quite confident that we are seeing improvements, which is the main thing. And I think that's about the sum of my updates at the moment, Chair, unless I'm happy for questions.
Yes, thank you. I mean, I like to see that you're doing the holistic approach, because it's no point having people offending and not getting help, and people have problems and not getting help. You need to look at the whole problem. You need to look at someone and perhaps capture them and help them before they get too farther down the line. I know we've been told before that heroin is mainly for older users. Maybe that's the case, but we still need to help these people. And I think that the problem with heroin is it might be perceived as an old person's drug, but opioids are still there, as we have discussed in the past. There's a problem in America. There's a problem in this country with prescription opioids, and I think the whole thing needs to be addressed. Do we have any questions? Councillor Story.
Thanks, Chair. Apologies for switching my camera off there. There was an incident with some leggings for my daughter's dance class that I had to address. It was very, very critical. So I apologise for disappearing. I wanted to ask about the sort of heroin-assisted treatment, but also, but not exactly that, but around the difference between treating drug issues as a criminal issue and dealing with it as a public health issue, because what I've noted from sitting on the police and crime panel is that heroin-assisted treatment and dealing with it as a public health issue is actually a hell of a lot cheaper than taking someone through the entire criminal justice process. And what I was wondering is, do we have comparable figures for the work we are doing now in terms of dealing with drugs as a public health matter and the diversion tactics and other things? Do we have a comparison between that and the cost of that, what would have happened ordinarily if we'd have done what we used to do and took people through the whole criminal justice process? Because I think if we could show the general public that not only is this the right thing to do for our communities because it is a public health matter rather than an issue of criminality, it's also cheaper for people and better for the public purse. And that's something that would have great resonance with people, I think. So do we have a comparison between those two things?
I'm going to have to admit I don't know at this moment in time in relation to whether we have a comparison or not, but it's a very worthwhile question in terms of the cost benefits of the heroin assisted treatment program compared to the probably criminal justice aspect and the costs that those people previously would have caused to society. So I can certainly take that away and have a look at the value in terms of the cost, but I completely agree. I would, in terms of what it takes to deal with someone for possession of any particular drug, is an officer detecting the crime, taking someone into custody, going through the custody procedure, waiting for solicitors, going through the healthcare assistance and the diversion, the interview, the going to CBS for charging if the case is denied, the then subsequent time of submitting the case file to go to court. It is vast. It is really vast for an officer to deal with that. What we are looking at is streamlined processes for dealing with people for possession of drugs at this moment. So you may have seen our officers carrying body-worn cameras. If there is no threat, risk or harm when we are stopping these people with very small amounts of drugs, we are looking at procedures to interviewing them on body-worn camera, submitting a streamlined case file outside of the court process, but at that very same moment, linking in with diversion services to engage that person with a support agency or the local authority or whatever service they need then and there to problem solve from the very beginning rather than 3 months down the line when it's stuck in the court system. So we are exploring that because a lot of valuable, visible police presence is being taken out by relatively low-level offending.
Thank you. Are you happy with that, Matt? Okay.
I think
Anybody else?
Jonathan's got his hand up there. I don't know if Jonathan
I
wants
just can't.
to
I can't see the thing at the moment.
Sorry,
John,
yes, hiya.
yes, okay. Go on, John Johnson. Go for it.
Thanks, Chair. I'm Jonathan Bowden from Public Health and lead on the addictions and vulnerable groups. And just to come in on that, I'm involved in the heroin assisted treatment programme as we've described in previous panel meetings. And we've got Teesside University colleagues acting as independent sort of evaluators and researchers linked to the heroin assisted treatment programme, who are capturing all that sort of data, counsellor story. So we will be able to see the comparison of those on the programme and what that has cost and the outcomes it's delivered versus the sort of costs that for the process that Daryl's just outlined, and how much the programme has saved. So yeah, just to reassure you that we are capturing all that, and there'll be sort of reports, papers, and various sort of news releases published as the scheme goes on. We have got a second year of funding secured as well. And just to say that we are working closely between Public Health and Cleveland Police, and we should be in a position to announce a sort of very high profile project, hopefully early in the new year, but just not quite in a position to confirm that just yet. But that will really help to drive a lot of the things that both Marion and Daryl have outlined, and that we've discussed in the past on this topic. Thanks.
Thank you. Any other questions?
Can I just say?
Carry on, Matt. Yes, absolutely.
I think what I'm trying to drive at really is, if we can see those two things side by side, I think the fact that we've got the fact that the outcomes are good is clear, and the fact that it works is clear. What I think would help for the general public, sense, is when we're talking about drugs and crime, a lot of people's natural reaction is, well, we should throw the book at them, or we should make sure that we're come down as hard as possible on people. What I think will be useful for people to see is that cost benefit analysis as well, of saying, not only can we prove that this works, but it's actually cheaper as well, because it's about, for want of a better description, it's about being able to sell what we're doing to the general public and bring them along with us, and make sure that the wider community feels that our options and the way that we address these issues is something that they're comfortable with. Because that means that those solutions are then embedded in society much more easily. So I think once that data is available, if we can see that reported and be able to point people towards that, I think that will be tremendously valuable.
Yeah, I think it's a cost to society in general. It's always best to cure someone, remove someone off a thing, than actually saying we're just going to arrest and arrest and arrest. You've got to go at the core problem, see if you can help these people. So I agree with that.
I'm happy to bring that information back, Chair.
Thank you. I look forward to that. Councillor, how are we?
Just on the back of what this discussion has led to, I think it's also important to note, and that's what Matt's getting at as well, that we need to shift public attitudes, don't we, from a total, perhaps, criminality perspective on people, and think more about the need to support them and get them away from difficulties that they face in terms of lifestyle choices. So I think it's also important to really be sure that we try and move public opinion and attitude in a different way.
Yeah, thank you. Councillor Cooper, do you have a question?
Thank you, Chair. It's not so much a question as just a point that I'd like to remind people of. I'm all for treating people medically. I've been a first aider for about 40 years now. But I think we should also remember that where there's crime, there's victims of crime, and we shouldn't lose sight of their needs in these matters. Thank you, Chair.
Thank you. Well, you have to always see all sides, but but getting someone off drugs and helping them and stopping them taking drugs is where we should be going. We're not trying to glorify the use of drugs. What we're trying to do here is to try and help someone and take them off the drugs. I think that's where we're going. Any other questions? I don't see any at all. Do you have any other comments, Chief Inspector?
The only other thing I would say is that obviously in relation to the drug-related deaths, which every single one of them are tragic, there is a meeting review placed in every quarter now to discuss the numbers, the reasons, to understand trends, and to basically keep on top of. It's a multi-agency meeting to identify what we need to do to respond effectively. I know Scott's work with partners, with Jonathan and everyone else over the last 12 months has identified a lot of recommendations which follow the same sort of feel around the user, supporting the user, and basically making life a little bit better for those to give them the services that they need. I wasn't going to mention the other project. I was told I wasn't allowed to, but Jonathan saved my bacon and said he can. So, yeah, that's it. Thank you for giving the opportunity. I will stay on the line until 15:15, but then I'll just leave the meeting if that's okay, Chair.
Yeah, that's fine. Marion, do you have anything to add to what's been said, or you happy with what you said earlier?
Nothing further from me, Chair.
Does anybody else have any other questions for that? If not, can I thank you very much? That was very enlightening for all the presentation we got. I think there are maybe some diverse views, but I think we all want to see people come off drugs. It's not good for them. It's not good for society. And I think that the big outcome is if you don't take the drugs, if you don't have to take the drugs, you can perhaps come back into society. Whatever Middlesbrough Council and all the agencies, the police, etc., can do to help you, that's what we're here for. And I think that's most important. It's as Councillor Story rightly pointed out, there's a cost to society, and surely the cost would be better served if we're helping people, not just keep locking them up. Locking someone up is not just an answer. I think it's helping people. Locking up should be the last resort, not the first. Thank you. Councillor Howey, you have a question.
Could I just ask a couple of questions for Marion, please?
Please do, yeah, please go ahead.
It was on one of them was on the topic of the drugs raid that you mentioned, and you said that they're happening more frequently and they are more successful all the time. There will be data, won't there, around these raids about where they are, how often they're happening, how successful they are, and I wondered if it would be useful for us, please, to see that data at some stage. And then I wondered whether part of the issue about the frequency and the amount of drugs raid that happens, is the increase and decrease related to the need or the fact that drug-related issues might be decreasing, or is it related to capacity in terms of finance and personnel to operate the drugs raids? Because we find they come in waves, don't they? We get them and then they seem to stop and then we get some more. So I just wondered what the analysis is behind that sort of up and down method of conducting drugs raids.
Yeah, sure. I mean, I'm happy for Daryl to come in, but just very briefly, Chair, if I may, I think there's a couple of things. We've made some changes to the way that we kind of communicate with each other broadly. We have the daily briefings that we talked about earlier. Through our locality working, we've got staff on the ground, and we've been doing some surveys in Newport, for example. From the surveys that we got back from the locality working surveys, and the feedback we got from that, we conducted a week of action, a multi-agency week of action, and some of that included some direct action as a result of some of the information that we got back, which was really, really helpful. In terms of the data relating to drug raids, I think one of the other things that we've also done is, and I think Daryl alluded to it earlier, we have had some change, haven't we, in terms of the neighbourhood setup, and obviously, we've had increases as well in terms of our warden service, so we're able to gather more intelligence and share that more frequently. So I think there's a number of things really that's probably contributed to why we've seen a little bit of an increase more recently. Daryl, I don't know if you wanted to say anything about that in terms of drug raids. Drug raids always happen by the police.
Yeah, so from my perspective, and this is through my experience and my personal work, what I've done with the police, is that when people phone us up and report around drug dealing, whether it's a neighbour, whether it's on the street outside, whether it's causing them any anxiety or harassment, alarm and distress, we have to prioritise those, because those are victims indirectly to a crime that's occurring in their vicinity. And what we want to do is make that person or make that victim feel supported, feel that we're doing something about it, and to try and put some problem solving in place so that they can live in their particular area free from any risk of drugs, violence and antisocial behaviour associated to it. So the drugs work that has been increasing over the last 9-10 months is basically coinciding with our rebuild of neighbourhood policing and us responding to those community concerns that are directly phoned in or that are directly from the street wardens that are really having an impact on the community. And it might be a low-level dealer who is supplying cannabis, or it might be an OCG member who is making thousands of pounds every week through selling large amounts of drugs, counterfeit goods, you name it, but associated with violence also, because they use violence to intimidate. So the increase is due to resources and capacity, because we've got a little bit more to do, but it's also the right thing to do, because we can't not respond when people are ringing up saying that they're suffering mental health issues, they're suffering anxiety, harassment, alarm and distress due to the activity that's ongoing around them. And it's the right thing to do. But when we do come across the users and the lower level offenders, we deal with them in a proportionate way. So it all depends on the threat, risk and harm and the actual intelligence that comes in, which determines whether or not we act upon it and whether or not a response is required.
Okay.
Thank you for that.
Yeah, can I just ask one question? I meant to ask this earlier on. The Chief Inspector, does the police, any police officers carry naloxone? We've heard about the street wardens carrying it, and we know it's available. I'm not sure you were disappeared there. No, you're still there, I think. So do the police carry it, or if they don't, is any plans for the police to carry naloxone?
There has been some plans and there has been some trials. We have used it on specific operations where we've targeted high areas of drug supply, and we have trialled it. It's not been rolled out, but I believe it's planned for the new year in line with this project work that's going to kick off in January. So watch this space is what I'm saying around the front line carrying it.
Okay, Jonathan, you want to make a comment on that?
Yes, it is linked in with the work that we're doing in partnership with Scott Cowie. I think it just needs approval from a sort of board level approval decision from Cleveland Police, and we're looking at some frontline responders carrying the nasal naloxone kits, which is obviously presents less risk compared with the injectable naloxone. But yeah, we're very hopeful that will be imminent.
Yeah, because I gather now it is available or it will be available as a nasal rather than an injection, which would be obviously more convenient for an officer to carry. I would encourage them to do that. Thank you.
And if I may, Chair, what I would say is, if it's possible and if it is just as effective, then I would certainly be interested in looking at kind of swapping over the injections that we carry at the moment for the nasal spray, because it does minimise risk even further.
Absolutely. I understand from what I've been told that the nasal spray is just as effective. It's just available on the market now. I could be wrong, but I think it would put less problems in your way, if you know what I mean. So it's just something looked at, and I would absolutely encourage Cleveland Police to look at carrying that. Sorry, Alma, do you have any more questions to put there? I interrupted you.
I just had one final one. It was around the issue of the community safety plan, which you mentioned, Marion, which you said is reviewed every 2 years. I just wondered if, I imagine that you monitor it frequently in your different meetings, do you ever or find sometimes that you need to make significant changes to the way that you're reacting to the issues that are there in the plan? Or do you find that it's more or less in line with what you were thinking in the first place?
So the issues rarely change, if I'm honest. They pretty much stay the same. The areas, the geographic locations to which they may kind of spring up, they sometimes shift around a little bit, but pretty much the issues stay the same. There might be, every now and again, you might see something different that comes in there. What we have the ability to do is we say at the high level strategically, this is what we're going to do. And it might look different and set out differently because it might change our focus slightly. And we need to make sure that we're not having like 15 or 50 priorities, because in reality, if we can narrow that down to 3 priorities, we're more likely to have a better success or chance of success on those things, because actually those are the things that create the, if we can tackle those things, we'll start to turn the curve on some of the other kind of significant or wicked issues that we might have out there. What we do have the ability to do is we've just reviewed that community safety plan. So we're now in the process of developing action plans for all of those. What we do is if we identify something new that falls under that kind of banner, we'll add that in. Absolutely. We won't wait for 2 years or even a year or whatever before we kind of review that. We'll absolutely, when we have, there's operational meetings and there's strategic meetings, and if we need to, we'll adapt those plans as we're going along. Absolutely.
Thank you. That's good. Yeah, I just wanted to know about the flexibility and adaptability of the plan and your reaction to it. Thank you. That's fine. Thank you, Chair.
Thank you. Are there any other final questions? I don't see any hands up. No. Well, can I thank you for attending very much? Can I thank Chief Inspector and you, Marion, and Jonathan, etc., for attending this meeting? It's been very interesting. It's been very useful, and I think even if we get something out like the naloxone and things, I think that would be an achievement. And getting the perception of, a drug user is a victim as well. They're a victim of drug dealers. So it goes all the way down the line. So I think I quite understand where Barry's coming from, but I think we need to help people as well. We're a council and we're a community, and we need to help these people as well as we help the community, but we need to help these people. And the more people we get off drugs, the better. Thank you. You can stay as long as you wish.
I'm going to leave now, Chair. Thank you.
That's fine. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye.
Thank you. Bye-bye. Right. The next item is the COVID update that we have. Mark, it's over to you.
Hello there. Thank you very much. I'll try and share my screen for I've just got a brief presentation of the figures that we've got. Can people see that?
Yes, thank you.
This is it says 9th of December. I think it was produced for the SCG tomorrow, but it's relevant as at today. So I guess if I just go on to this one first, not that one. That one. You can see the rate of Middlesbrough's cases. This is 7-day rolling average of cases up until the 6th of December. So you can see that when lockdown happened and we continue to rise because there's a bit of a lag, and then from the 12th of November at a peak of 506 cases per 100,000, we've dropped pretty steadily, but then there's this kind of flattening out that's happened in the last week or so at around about 180 cases per 100,000. And what just go back to the start of this. What Ali's done is pull this together against the metrics that they use to determine which tier will be in when they look at it on the 16th of December, where they'll probably be using data up until about the 9th or 10th of December, so not too dissimilar to this data. You can see in the northeast all of the areas are falling, and some of the areas of quite dramatic falls. Gateshead down to 95 per 100,000, Newcastle 120 per 100,000, Redcar and Cleveland's quite low as well, although Redcar's flattening out as well. So that just sets in context where Middlesbrough is compared to the rest of the northeast. Looking at the way that the tiering system is likely to be done is in considering the Tees Valley, the 5 authorities in the Tees Valley and the 7 in the northeast as 2 separate areas rather than 12 northeast authorities. And basically we're kind of tracking each other pretty much anyway, particularly since lockdown, where We were higher than, well, still are slightly higher than the Northeast 7, but we've closed the gap and are now a very similar rates to those north of the patch. Looking at the Tees across the Tees Valley, again, at various points in that, Authority A said, well, why should we go into lockdown because we're lower rates than you, but actually, or, we're higher rates than you and we want to go into lockdown. You can see that effectively all the areas kind of follow each other pretty much. Darlington's perhaps had a slight, which is the purple line, has had a slightly sort of flatter trajectory, but now but has gone from being bottom of the pile to somewhere near the middle to the top of the authorities. But we're all clustered round about that. Wrexham Cleveland's the lowest, and Middlesbrough's round about the middle of the pack at 179 cases per 100,000. And that's about what it is at the moment, the latest reported figure. If you look at these are the numbers, that was the 7-day rolling average. These are the number of cases per day, the day that the specimen was taken. So you can kind of see that that's falling, but quite flat. It's still falling, but falling at a lower rate from around about the 23rd of November onwards. And we looked at this graph with the sort of flattening curve. So I think before it started to flatten out, I was quite certain we'd end up we'd potentially head for tier 2 because of that really swift rate of decline. I think we're flattening out at quite a high rate. That if I was betting, I'd say we'll probably end up in tier 3. But there's no thresholds published in terms of if you're above this, you're in tier 3, and if you're below it, in tier 2. So there's a little bit of guesswork in that. One of the things they look at is the positivity. So of those people that are turning up for tests, how many are positive. Middlesbrough's rates previously were around about 16-17%, so they've dropped a lot, which is really encouraging. And again, you can see the other areas in the northeast have dropped in terms of their positivity rates as well. And obviously the numbers getting tested are falling because it's symptomatic testing that's available. One of the metrics they look at is 60 plus, the rates amongst 60 plus, which is largely driven by, not exclusively, but largely driven by care home testing. And you can see the yellow line there is the 60 plus age group, which has come down from a peak that was driven by a number of care homes testing and finding positive, but largely asymptomatic cases. But our over 60 rate is low. I think it's high in. I think it's Darlington that's high, that would push the Tees Valley 5 rate as a higher rate. And then looking by ward, I won't go into this in any detail, but around in terms of the community testing program, which we're looking to plan for after Christmas, part of what we'll be looking at is, so this excludes care home testing, looking at those wards, particularly that have got a high positive rate of testing, which would indicate that really there should be more testing being done in those areas. And it's organised from the most deprived areas to the least deprived areas. But you can see that there's an issue all the way through those areas, really, with Ladgate having the highest positive test rate, which and quite a high rate of testing as well, which would indicate there may well be issues within there. But I mean, I think there are issues in all wards, not to settle on any particular ward in particular. But this analysis will drive our thinking around where we site some of the testing stations for the lateral flow testing. Hospital activity is obviously a key metric that they look at, although they haven't determined specific metrics. But you can see there the inpatients falling from a peak around about the 23rd of November, but again flattening out in line with the community activity. I'll just move you out the way a little bit. The new admissions fell sharply, but as flattened out. So this is over 7 days, rolling average over 7 days. So around about 10 new diagnoses or admissions with COVID every day at the moment. So we'd really want to be seeing that continue to decline. And then this is the main thing to pick up here is the red graph, the numbers in critical care, which again have fallen, but starting to stabilise at quite a worrying level should the numbers start to pick up again. And then this is the excess deaths. So you can see the whilst this has week numbers rather than months, this is March, April, May time, where obviously we had a significant impact of COVID, and we are seeing relatively small numbers of people with COVID as the cause of death, but still below the average that we'd expect to see at this time of year. The dashes of the 5-year average mortality rate. So small numbers of people that have died as a result of COVID, or where it's mentioned on the death certificate, but our rate is still below what we'd expect to see at this time of the year. So that's a trot through the position, really, just to inform, I guess, perception of which tier we're likely to be to come out of. And I think the tiering arrangements are a mixture of the numbers, and I guess there's an element of political lobbying that comes into it as well, as you've seen where London has come out. It was tier 2 and we were tier 3, although some areas of London had higher rates than we did where we are. So I'm happy to take any questions on that or anything related to COVID, really, but I'll pause there, Chair.
Yeah, thank you. I'm interested in what you say about the what the government or whatever looks as the criteria to put us up or down or keep us where we are. Judging by your figures, it's not looking as good as I'd hoped it would be this time. It looks like we may still remain in tier 3. I have noticed, looking at the figures the last few days, that we've is leveled off, etc. Although the look north and things last night were showing the whole of the northeast coming down and down and down, which it is. But it does seem a point that we appear to have reached a point where we've reached equilibrium, if you like. And so, what do we have to do to get below that line? I mean, we still see people going to shops without face masks. We still see people, not many, but there's still people out there which are perhaps not observing as much. And you're quite right about London. Sometimes when you look at the London figures, you wonder why on earth they're there. But then again, I think politically we can see that why that was. Anybody has any questions for Mark on that? Matt, you have a question, followed by Denise.
Yeah, thanks, Chair. Mark, I just wondered if there was any concern about the 16th of December is the date that the government have set for reassessing what tier areas are in. Is there any concern that should we get to a point where we're potentially going into tier 2, that's quite a bad time to sort of lessen the restrictions on the basis that we're running up to Christmas. We've got the 5-day break over Christmas, which SAGE themselves say could have a significant impact on the rate of infection. If we got to the 16th and we went into tier 2, that's like when people may want to pile into the shops and I don't know, go out and do various Christmassy type things. Do we have a concern that might not be the best time to release restrictions? I mean, and do we feel as though we may get to a point where that's actually even possible? Bearing in mind we don't really know what the criteria are.
I think if I was betting, I would say we're likely to be in tier 3, but because there's no thresholds to say, to have a kind of explicit judgment of that, it is a bit of a bet as to what the process is from a public health perspective in terms of managing COVID and putting the kind of economic implications, which I know are important to health in the longer term as well. But just considering the case numbers at the moment, tier 3 would help us manage the numbers down as much as possible. You've mentioned the Christmas period. That's my biggest concern is the Christmas period and how that sort of relaxation for those 5 days could potentially lead into a big impact on community rates and then into the hospital. And we've seen once it starts to grow in that way, it becomes very, very difficult to contain. My aim is to get it as low as we possibly can before that period, and then we're building up our capacity for contact tracing, and we've changed a number of processes so we can access data locally sooner than we could before. Well, we couldn't access it at all before, to do the local contact tracing, and building up our capacity to act as swiftly and as appropriately as possible. The impact that has depends upon how low the cases are when and if they start to pick up. If they're picking up from 120, 130, 140 per 100,000, it becomes more difficult to determine where the infection was found if somebody has been tested positive, because it could be any number of places. The lower it is, the easier it is to find clusters and jump on them and support people to isolate and prevent the transmission. So that's sorry, a very convoluted answer to quite a specific question. I'll pause there, otherwise I could go on forever.
Just before call Denise in, just one quick question. What's happening to these tests? We keep hearing about these 10,000 tests and these flow tests, and they're going to happen, and the lorries left where the factory is. Where actually are they? Have we got them yet? Are we going to get them yet? And when are we going to get them?
We've got so there are two testing streams that both cover much the same ground, really. So there's what was called the mass testing, which is now called the community testing program, and then there's the tests that were allocated to the DPH and that program. So one program comes with a finance allocation per test delivered, and obviously a cost of delivering the tests. And the DPH program comes with no additional resource. So obviously there's a impetus to push as much in the community testing work stream as possible because it generates an income. We're working through at the moment. So I think two things have happened at the same time. There's the kind of political push that is get everybody tested, get on with it, and then there's a sort of bureaucracy that's rolled in behind it and dumped hundreds of pages of stuff on us that we have to try to work our way through and figure out how do we do it. You know, there's standard operating procedures and forms to fill in and processes to adhere to and training to be delivered and all that kind of stuff. So we did have. So I oversee Middlesbrough, Redcar and Cleveland. We did have a community-led pilot in Middlesbrough and one in Redcar and Cleveland. The Middlesbrough one didn't go ahead because we were working with a mosque in Middlesbrough and they got a little bit concerned about potential for cross-infection with some of the other things that was happening in the mosque, which is fair enough, but we'll still pursue that for January. The community-led testing pilot in Grangetown in East Middlesbrough is going ahead next week, so we'll get some learning from that. I know it's not in Middlesbrough itself, but we'll get some learning from that to inform how we work the programme moving forward. What we're looking to do from after Christmas is have a large testing site, possibly in Middlesbrough Town Hall, and then a couple of medium testing sites possibly in Middlesbrough Sports Village and another one to be determined, and then smaller, more local sites working with local VCS and community organisations to work to encourage the take-up, because the experience of Liverpool, as people have seen, and I think we might have talked about here before as well, is in some of the poorer wards, the take-up was as low as 4% for the testing. So we want to make sure that we target and work with people to support them and you know, bust any myths that there might be about testing, make sure people are aware of the support that's available, both financial and non-financial, so that everybody's equally able to do the right thing because they're aware of what support there is to them, and those sort of negative financial consequences potentially will be taken care of with the package of support that we've got for people. So after Christmas, we will have developed a programme of testing from sort of large testing site, medium testing sites, and small, very community-focused testing sites for a period of around about 6 weeks. But there's a whole raft of detail that we've got to determine yet, and I guess a sort of it's quite difficult to work through the process in a systematic way, because we get quite a lot of external pressure of getting things done from the military liaison team that have been given one set of instructions that are perhaps a little bit contrary to some of the bureaucracy that we've got to work through before we can engage properly with it. But we're working to try to have a coherent set of approach to testing after Christmas to pick up that spike that we talked about.
Yeah, thanks for that. The other thing I was going to mention, of course, is the injections, the actual vaccine that start today. I'm also aware that Councillor Rooney and also Councillor Cooper want to come in there, but I didn't want to hog the limelight. But do you really, are you hopeful now that I know it's going to take a long time to roll out? It's not going to be simple. It's not going to be 1st of January. Everybody's going to think it's going to take till perhaps March, April time before everybody's going to get it, and I'm sure it'll be rolled out fairly. But it's just something that we need to do, because without the vaccines, we'll have as many lockdowns as we can. It'll just keep coming back.
I think it's encouraging that there's obviously a vaccine that's been authorised. I think it's a kind of messaging thing that worries me, really, because I think we get the message that there's a vaccine here, you know, the end is in sight, which is fine. But I think there's a fair bit of grind we've got to go through before sufficient numbers of people are vaccinated to change the status of it. And I think we'll probably see from round about March, April time more of the mass community vaccinations happening, and up until that point will be priority groups. So I think we're probably looking till sort of early summer that we've actually got both a diminution in the virus, because it lessens in the summer anyway, and sufficient numbers of the population vaccinated for that to have taken effect. So I think what worries me is that kind of the vaccinations here, everyone's going to get vaccinated in the next couple of weeks kind of message plays into the we can relax at Christmas because there's a vaccine. So there's a whole raft of things that I think potentially add to a bit of a toxic mix of messages that might make it easy for people to think that doing the wrong thing is okay because the vaccine's in sight. So I'm quite worried about the messaging of it. But in the sort of more medium term, I think it's obviously a great thing that there is a vaccine available, and another one, the Oxford AstraZeneca one, on the way as well. That has a less arduous cold chain, which would make it more able to get into communities to support vaccination of as many people as possible in those communities.
Yes, very important. Yes, sorry, Denise, you put your question now. It's
okay. I think Mark's probably covered what I was going to say. I was going to ask about. Thank you.
Sorry about that. Councillor Cooper, you had a question.
Thank you, Chair. Yeah, actually, it was more or less what you said. First injections were at 7:30 this morning. What the reports don't say is how many people were done. But what I have seen in other reports is that there seems to be more vaccines than there are people able to administer them. And I'm wondering if that's the case, if we should now be thinking that instead of our test sites being test sites, it should be converted to treatment sites so we can actually get people given the vaccine. I'm just wondering if you had any comments on that. Thank you.
I guess that I wasn't aware that was an issue, and I know locally the rollout is James Cook focused in the first instance, and there's a number of primary care sites I think that will come on stream next week, and then it'll the number of sites will broaden the week after that. It's a difficult balance, isn't it? I think we have to do both. I think there's understanding how we manage the here and now whilst the vaccination program is rolling on, because I think that has a longer time frame than weeks. I think it's months before that gets rolled out to people, so people will still need to do the preventative measures, the hands, face, space, and isolate when they're found to be positive, and look out for symptoms and all the kind of things that we've been doing since March. So I think it's necessary to do that in parallel with the vaccination program. I don't think that you could, even if you started the program now and everybody was lining up to be vaccinated, it's still going to take months to get through the numbers that we've got to get through. So I think you have to do both at the same time.
I understand that. I mean, I know a retired health professional who's volunteered to help do the vaccinations. I know they're looking for people now. As long as we have the space, I mean, you've got the town hall, you've got the sports villages. There's plenty of places we as a council can provide, as long as you've got the professionals to do it, and we've got the vaccines. You mentioned the AstraZeneca one, which hopefully will come online very shortly, which, as you say, doesn't need the colds so much. I think we need to get on with it, but I know that's not as an easy thing to do. So I think we need to build up the confidence in it. We need to build up the confidence that people can take it and it is perfectly safe. And then as we do that up, we will hopefully come out of this in the springtime. Hopefully we'll come out of tier 3 long before that, but we'll just have to see. Any other questions we have? Yeah, Councillor Story.
Thanks, Chair. Yeah, I just wondered about in terms of the hospital and how they're reacting to what's going on. Have we seen, in contrast to the first lockdown, have we seen an increase in therapeutic treatments? And because obviously we didn't have a lot of therapeutics for the people who were presenting with COVID in the first tranche of COVID when we were in the first lockdown. So how is that working? And do we have like data on how much the therapeutic treatment's been delivered and how that's working in practice?
I think there's a lot of learning from the first phase of COVID that's played into how people are treated. So it's less. I guess it's a more known quantity now than it was in March, April time, where it was even things as simple as people lying on the front to improve the breathing and improve their outcomes. From simple things like that to different therapeutic treatments that have come online since. The difficulty with the hospital is because they're treating COVID patients and basically running their normal business at the same time. It's been very difficult to get any metrics out of the hospital at any more granular level than those that we've been through in the presentation a bit earlier. So it's difficult to find that out. Every so often we're able to connect into some of the stuff that they're doing anyway and see what's happening, particularly around some of their modelling details. But I don't have specific details of. I saw some early details of kind of mortality rates lower now than they were in March, which would suggest that the treatment regime, well, people are either being admitted earlier because they're more aware, and GPs and other kind of infrastructure are more aware of what they're looking for than they perhaps were in March, and the treatment regime is better, and it's a more of a known entity than it was then. But I don't have anything more specific than that.
Thank you. I mean, going on from that, if you look at the trends and things, and you look at how many people are in hospital, I think the outcomes, it's not just the fact that people are in hospital, it's the outcome at the end, that they come out of hospital as fit and healthy as it can be. And they're not, I know long COVID is something that we don't quite understand yet, but I'm sure we will understand and find the appropriate treatment. There was a film recently about an explorer who was determined, who actually had long COVID, and he climbed the local highest mountain in Cornwall and things to prove at 80 you could still do it. So there's encouragement out there, but I think the more we understand this illness, the better the outcomes will be, and try and reduce the deaths to zero. I think that's the great achievement, and then obviously the spreading of the virus is important. Any other questions? Brian, I can finally see you, Brian. Yes, you've got a light shining above your head. It's sort of stopping me seeing you. Councillor Hubbard, please go ahead.
It doesn't help with my head as well, I suppose. It's like a double light. I don't know whether you'd be able to help on this one, Mark, but do we have any figures of the uptakes in the flu vaccinations? And is it expected that there'll be a reduction in deaths caused by flu due to people wearing masks and washing their hands more frequently? Thank you.
We've got some figures. I haven't got them to hand. I think the kind of total numbers are higher in terms of people that have been vaccinated than we've had in previous years. Some of the granular detail about specific age ranges is there's a few bits where we need to improve the figures that we've got, but in essence, the vaccination take-up has been significantly higher than it has in previous years. And yeah, you're right. All of the measures that we're taking for COVID about distance, washing your hands, and sort of respiratory hygiene and all that sort of stuff are all exactly what you'd need to do to reduce the impact of flu as well. So in Australia, that's obviously already had their winter, had very little impact from flu. So I would imagine that the impact of flu here would be less than we would normally expect to see because of all the measures that are in place to prevent COVID.
Thank you. Thanks, Chair.
Thank you. Any other questions? Well, thanks, Mark, for that update. You've been as clear and concise as you could. I mean, you're basically telling us that what to be expect. I think people need to know if we're going to stay into tier 3. I think people need to know as soon as possible, and then face the things about that. Councillor Story was and Councillor Rooney mentioned earlier on. I mean, we're coming up to Christmas now, and perhaps if we're going to have a spike, that's when we're going to have it, and then January might not look so good. So staying in tier 3, I'm not sure that's the answer, but I think if we came out of it, we might have to go straight back in. That probably is not the answer at all. So I think we need to address the problem and try and get people to accept what the consequences are, and to put masks on and to keep social distancing. I'm just concerned that it's leveled off. I'm just hoping it's going to start to go down again as soon as possible. and we can get away from this horrible disease. But thank you for coming today.
Thank you.
Yeah, please stay as long as you like. The next item, I think, is item number 6 on the agenda, which is Regional Health Scrutiny update. I don't know whether that's going to be Alma. Is Alma still there, or I'll put it to you, Caroline, and then you can...
Would you like me to take that, Chair? I can just give a brief update.
Yes, Caroline who was going to do this. Yes, thank you.
Yeah, no problem, Chair. It was just to let everybody know that the Tees Valley Joint Health Scrutiny Panel met on the 20th of November, and we received a presentation at that meeting in terms of the local COVID response from Mark, whereby he provided information from the statistics, not just on Middlesbrough, but across the Tees Valleys, and comparative figures on that. We also received an update from Tees Esconway Valleys NHS Foundation Trust on the Teesside Rehabilitation Services Development update that they're doing at the moment. The works that have been going on at Rosebery Park, that was a piece of work that the Tees Valley Joint Health Scrutiny Committee had done previously, and we received an update on that. And there was also an update provided on Wesley and Hospital. And the panel also looked at the work programme and future meetings. That's all. Thanks, Chair.
Thank you very much. Alma, do you have any comments to make on that, or you're happy with that?
That's excellent. No, we covered all those items. It was a very interesting meeting, actually. Thank you very much. Yes, the detail was interesting, wasn't it, Caroline?
Thank you. Right, next item is the Overview Scrutiny Board. Now, unfortunately, it's the only meeting I think I've missed in the last 17 months, so unfortunately I couldn't attend that. I don't know whether either Caroline or Joan or whatever can perhaps give an update on what happened at the OSB.
You don't need to give an update. Sorry, Joan. Yeah. Sorry, Chair, just a second. Yeah, so obviously, in terms of OSB, the OSB board met on the 20th of November to consider a call and request regarding decision taken by the executive on the 27th of October in respect of the future office accommodation. The outcome of the call and meeting was to refer that matter back to the executive for reconsideration. The executive reconsidered that matter at a meeting on the 24th of November 2020. And the recommendations proposed by the Overview and Scrutiny Board were noted but not agreed on that occasion. The Overview and Scrutiny Board also met on the 3rd of December, where it looked at the Executive Forward Work Programme, Middlesbrough Council's response to COVID-19. An update was received from the Executive Member for Environment, and also all of the chairs, scrutiny chairs, gave their updates. Thank you, Chair.
Yes, thanks, Caroline, for that. Does anybody have any comments on that? No, thank you. Well, it's been a very interesting meeting, I think. I think we can all agree that I certainly learned quite a bit as well. And I think that, the town now needs to know what's going to happen. And I think we need to move on from here. Because we all seem to be at the top of the wrong league table and the bottom of others. And I think that's not what anybody wants from Middlesbrough. I think we all agree with that. So the next item is any other urgent matters. I'm not aware of any. So unless anybody has anything else, I'll thank you for attending, and we'll see you at the next meeting. Thank you.
Thank you, Chair. Goodbye, everybody.